My name is Angela Wilson-Panisi. I'm a physical therapist and owner of Lakeshore Sports Physical Therapy in Chicago. Our therapists have been working with patients following treatment for breast cancer over the past several years. And what we found in talking with patients and physicians and nurses and case managers, that it can be very difficult to stay on top of all of the information that's available in terms of how to best help patients reach their maximum potential following treatment for breast cancer. And so we've prepared this series of presentations to assist with that process. Common issues for women following treatment for breast cancer include lymphedema, or swelling of the arm down the side that was treated, limited shoulder mobility, difficulty reaching overhead and things like that, myofascial pain syndrome, which is development of tender points in the muscle that can be present at rest or with movement, muscle weakness, and also you start to see a change of trunk and shoulder posture. The tendency to develop lymphedema or swelling in the arm really is dependent on what type of procedure or treatment that a woman undergoes. In 2012, Shah identified that the risk factors for lymphedema development, including having had a mastectomy, having had an axillary lymph node dissection, and this change to sentinel node dissection versus the axillary lymph node dissection has made a significant difference in the frequency of women developing lymphedema. And also that there's an increased risk of developing this if you have treatment with radiation and chemotherapy. Restricted shoulder mobility is a common complaint, many times not really recognized until after treatment is complete or noticeable until they are starting to get back to their normal daily lives. But 1 to 5 years after treatment for breast cancer, nearly 1/3 of patients still report painful and restricted shoulder mobility. And this can be contributed to by something called axillary web syndrome, which does occur in 28% of women following surgery for breast cancer. And what you see is this sort of webbing of the tissue underneath the skin. Again, if you have a sentinel node biopsy instead of an axillary lymphadenectomy, your risk decreases by 68%, which is significant. Myofascial pain syndrome is the development of trigger points that are sort of these little hyper-irritable nodules of tenderness that are developed in a taut band of skeletal muscle. And when you touch them, it actually refers pain, or pain will sort of radiate out from that point. And this occurs in 45% of women 12 months after surgeries that included lymph node dissection. The muscles most commonly involved would be the latissimus dorsi, which is a big muscle that goes down your back. The serratus anterior sits right underneath your shoulder blade, the pectoralis major on the front of the chest wall, and the infraspinatus, which is right behind your shoulder blade. And this is most likely to occur at about 6 months after surgery is when women will start to notice these types of irritable nodules. Other common impairments include shoulder weakness. When Merchant in 2008 evaluated 40 women following treatment for breast cancer, they identified weakness in the extensors, the shoulder retractors, and the protractors, so the muscles that basically move the shoulder blade around. And you start to see an impairment of trunk and shoulder posture, this sort of rounding forward. And this is much more common for women following mastectomy when compared with healthy women. But the good news is that at 1 year, women who participated in rehabilitation and regular exercise demonstrated less of this forward inclination of the trunk and had a better upright posture. Physical therapy treatment can be very effective in addressing these impairments and limitations. Though many women are advised to do exercises after treatment for breast cancer and after surgery, the women who receive physical therapy treatment improve their range of motion, and their functional recovery is significant both initially and over the long term and across multiple surgical procedures. And this has now been demonstrated in multiple studies. So when should women be referred for treatment by a physical therapist after surgery? MET in 2005 followed 139 patients after either having mastectomy or breast-conserving surgery. They had 12 PT sessions approximately 6 weeks after surgery, and this resulted in improved shoulder motion at both 12 weeks and at 6 months when compared with the controls. But even if the care was delayed by 6 months, the treatment was still effective because both the control group and this early intervention group demonstrated similar results at 12 months. And in a systematic review conducted by Chan in 2010, they concluded that early introduction of exercise was valuable in avoiding deterioration in range of shoulder motion, and that early versus delayed physical therapy intervention did not increase the risk of developing lymphedema. So one of the questions is, who should see a physical therapist? Well, in 2012, the factors that were most associated with early range of motion impairment were identified to be having had an axillary lymph node dissection with removal of greater than 15 nodes, having undergone mastectomy, or having stage 2 or greater breast cancer. Also, the women who are more likely to still be impaired at 12 months, those women had positive nodes, were an older age, and had a BMI of 25 or greater. So again, when you're identifying your patients and looking at patients who may best benefit from referral to a physical therapist, in particular, patients who are sedentary or older should really be considered more quickly for physical therapist intervention. Other factors associated with poorer outcomes following treatment for breast cancer include having had radiotherapy to the axilla, if the patients themselves rate their health to be poor or their physical condition to be poor, having minimal physical activity in their day-to-day life, since they found that if women did have increased levels of exercise, they were less likely to experience some of the side effects that we've described. So they had better outcomes when it came to shoulder range of motion, less chest wall pain, less complaint of breathlessness, lymphedema, or weight gain. And the SF-36, which is a measurement, a self-perceived measure of health, if you had a lower score on the SF-36, that was also associated with having decreased shoulder range of motion, but not necessarily associated with the development of lymphedema. And interestingly enough, having cancer on the left side was associated with higher levels of scapulothoracic dysfunction and higher rates of pain and disability. And we don't really know why that is, but some of the theories include, of course, more patients are right-handed than left-handed, and so perhaps through using the arm more, now if it's on your right side, you start using the arm more quickly and you have a better outcome, which is a possibility. But another component to consider is that the diaphragm, the muscle under the rib cage, is actually an asymmetric muscle. It's not the same on the right and left sides, and as a result, the left side of the diaphragm is sort of underpowered, and you see less chest wall movement on the left. And so that asymmetry of our own anatomy may bias us towards having less mobility on that left side of the body. 35% of patients treated for early breast cancer are at risk for shoulder disability. Other factors include age greater than 60. If your patient's describing symptoms of depression, these are factors that are associated with a poor outcome. And specifically, if they have the presence of scapular winging, that's also associated with increased risk for shoulder morbidity. And the way to identify this is to have the patient press the hands on the wall, and you look for any winging of the scapula away from the body. In fact, 11% of women who underwent surgery for stage 1 or 2 breast cancer developed this type of winging due to palsy of the serratus anterior that occurred after surgery. So knowing what we know about the types of women who would benefit from seeing a physical therapist, some of the recent studies have really looked at how can we identify appropriate patients early and intervene when the treatment is more cost effective. So there was a prospective surveillance model proposed, and they identified that patients could be evaluated preoperatively to establish their baseline, so we would know before surgery how much range of motion do you have in your shoulder, how strong is your arm, what's the volume of the limb, so we'll be able to easily detect swelling when it occurs. What are those anthropometric measures like body mass index that we could identify those quickly, a person's functional status, and identify their level of physical activity. Then education could be provided postoperatively in the plan of care, including exercises for range of motion, restoring their strength, advice on returning to activities during and after treatment, and how to monitor for some of the signs and symptoms of early adverse effects of treatment, like the development of pain, joint mobility, weakness, and swelling. And if you followed up with these women every 3 months for 1 year to identify early signs of lymphedema or other restrictions, you could provide additional intervention or additional education. And so just looking at the model of when women would be screened in this prospective surveillance model, there would be a certain number of women who would be identified to have lymphedema subclinically, and those women would be treated when it's easier to treat. Versus if we wait until we identify that that same number of women are not referred for treatment until it's very symptomatic, the overall cost, even when you monitor the women who turn out to not have any problems, is significantly less because you catch the women who are having issues much more quickly when it's much more cost effective to treat the problems that they're having. So we see these differences in our own patient. I bring to you two patient examples. First patient is 41, the other patient is 47. They both had the same procedure. They had a bilateral mastectomy with reconstruction and a sentinel node dissection. The first patient was seen 7 months postoperatively, and the second patient was seen 3 weeks postoperatively. Specifically, I draw attention to the left arm reaching forward, known as flexion. The patient who had delayed care had lost a significant amount of motion. Normal flexion is at least 165 degrees, so she was down to 102, as opposed to the second patient who had early intervention was only at 142. The first patient did make significant gains. She gained 38 degrees over the first 4 weeks of treatment, but she still had not reached the same level as what the second patient who was undergoing early intervention achieved. And then when we look at reaching out to the side for the right arm, they both started in about the same place at 102 to 105 degrees, but the second patient who was seen 3 weeks postoperatively achieved about 14 degrees more range of motion than the patient where there was a delay of care. And I think that what we see for these patients is an expression of frustration when we see them 7 months postoperatively, because they've already undergone so many interventions in the previous year that has already passed. They've undergone major surgery, many times chemotherapy, radiation. They're finally getting back to their lives, and now they're developing secondary complications, and it can be very discouraging and demoralizing for them. Some of the things that they express to us is, why didn't someone refer me sooner? And the other thing that they talk about is just the challenge of if they had been referred earlier on when they were off work and undergoing a lot of medical interventions, they sort of saw that as par for the course, like that's what they were focused on. They were focused on their health. But now when they return to work and to have to start coming to a therapy appointment a couple of times a week, it can be very discouraging for them, and they sort of start to feel like they're just never going to get out of this cycle of treatment for their cancer, and that they can't sort of escape from it. And that can be a little bit depressing for them, though they do respond very well to the care, and they get very excited as they start to make gains in terms of gaining range of motion, decreasing chest wall sensitivity, and that ability to wear a bra again are some of the most rewarding milestones that they achieve. So I look forward to your questions and your comments and the discussion. I really like to see women, as they finish the fight for their life, be able to have access to the quality of their life again. Thank you.